I welcome you all to the second week of this epidemiology course. Last week, you had the sessions on the introduction to epidemiology and the measures in epidemiology. I hope that you would remember whatever you have learned in those two lectures. Let me give a quick recap on the introduction to epidemiology. You all learned about the definition of epidemiology and how to quantify the problem and how to observe the pattern to get the clue for develop an hypothesis and to conducting research and how to investigate a health problem at population level. And also Dr. Manikam has described about the components of epidemiology and what we have to do as a first step to for any research. So we have to look for the time, place and person to develop the hypothesis. So from then, after that lecture, you had the lecture on measures in epidemiology. Now you should have aware about various measures in epidemiology, the numerator, denominator, and how to measure various events, such as incidence, prevalence, and other ratios and rate. So today's topic is, it's a very simple topic, descriptive epidemiology. So at the end of the session, you can able to understand the role of descriptive epidemiology for identifying problems and establishing hypotheses, and to explain how the characteristics of time, place, and person can be defined. So, how we can describe a health-related event or state or a disease at the population level. The outcome may be a health-related outcome, status, or a disease condition. And we have to describe the pattern of distribution of the, not only the outcome, we are also interested in the distribution of the exposure or the risk factors, such as the climatic variation and the environmental factors, infective organisms such as virus and bacteria, socio-cultural behaviors, socio-economic status, socio-cultural behaviors such as gender inequality, and various kinds of drugs and the vaccine, whatever is responsible for the outcome. So how we can describe a disease or health-related characteristic? It's nothing but 3 points or 3 factors. We can describe a health status or a disease based on the population level, based on their age, gender, ethnicity, etc. It is nothing but the demographic details of the population. And the second one is whether is there any variation based on the geography or the place. It can be a international variation or national variation, or within the rural and urban variation, or within a city and the outer city variation. So it is the geographical distribution of a disease. So first one is demographic distribution, second one is geographic distribution, that is called as place description, and third one is time, how the disease condition is changing based on the time, how the trend occurs, how when it is increasing, when it is decreasing, and when it is vanishing, or again when it is again re-emerging. So these are all the factors we are going to see today. If you ask why we have to describe a disease or health related characteristic, why I am repeating again and again along with the disease, this health related characteristic is, epidemiology is not only deal with the disease condition or illness, it is also concerned about the wellness or any health related characteristic in the population. So why we have to describe a disease? To check whether is there any pattern is there, and we have to identify the pattern by examining characteristics of time, place, person, as I said earlier, and from that information we can get a frequency of a disease. It may differ in various circumstances based on these 3 factors. When you are looking for the frequency, that is the pattern of the disease, pattern of the condition, we can look for the three angles. That is, one approach is whether is there any differences, or is there any similarities, or is there any correlation. Here I have given three examples. So for differences, say like example, stomach cancer is high incidence in Japan compared to other countries. So you can observe the difference and you can report that. Another one is similarities. So among the intravenous drug uses, we can see the high prevalent of HIV/AIDS condition and also the recipients of blood transfusion. This is the similar characteristics among who is getting affected. And third one is correlation. So we are not going to stop only with time, place, and person. After recognizing these conditions and variables, we would like to check for whether is there any correlating factors, is underlying factors is or there. For example, for coronary heart disease, it vary, the differences of prevalence or incidence of coronary heart disease vary with cigarettes consumption. So here there is one another term is analytical epidemiology. I'm not going to deal with that in detail. You would be having a separate lecture on study design. It would be followed by this lecture taken by Dr. Jayashree. So here I'll be giving the basic difference between the descriptive epidemiology and the analytical epidemiology. So again, by reiterating, this descriptive epidemiology is we are interested in when is the disease occurring, that is the time distribution. The second one is where it is occurring, that is place distribution. And third one is who's getting the disease, why someone is getting the disease and some other person is not getting the disease, that is the person distribution. So this analytical epidemiology deals with the two questions, with these two questions, how and why, that is related to the causal factors. So now we are in this lecture, we are not going to deal with that. Let me tell you the steps in describing that is the procedures of describing a disease or health status. The first point is we have to define the population to be studied. Number one. Number two is we have to define the disease under study. Whatever the disease or any health status, if you are interested, you have to define that before you start the study. And the third point is describing the disease by time, place, and person. So this is the part we are going to deal in detail. And next one is measurement of disease, fourth point, that already you have get introduced. And then fifth is the comparing with known indices. So we have the measurement in our hand, so that now we can compare with the known indices or with the other countries or with the previous historical data, we can compare. And at last, the ultimate objective of the descriptive studies to develop or formulate a research hypothesis. That is the final step. So now in this lecture, I'm going to describe and explain up to 3 points, because fourth point already dealt. So fifth and sixth, I'm not going to touch. It will be dealt in separate lectures. So as a first step, defining the population. If you take any population, we have to have a clear-cut idea about among which population you are interested in, whether among the pediatric group or among the male only or female only or based on any occupation you are interested. So these are all the factors, that is the population base: age, gender, occupation, cultural characters, and socioeconomic conditions. They will formulate this population base. So you have to have a clear-cut idea about on which population you are going to conduct your research. So it will give you the denominator, which is very, very crucial in epidemiology. You might be very much aware after learning this measures in epidemiology, the importance of the denominator. Next step is defining the disease under study. So we are not going to stop only by defining the population. The second step is we have to define the disease on which we are interested in. To obtain an accurate estimate of a disease in a population, we have to be very much clear about the disease, what I'm going to study. So that disease definition should be precise and valid to identify those who have the disease from those who do not. If I don't have any clarity about my operational definition, that which condition I'm interested and the outcome which I'm interested, I cannot differentiate between the diseased person and those who do not have the disease. So technically speaking, that is called as operational definition. So this operational definition should be defined during the protocol development itself. That is the, when you are consuming your study itself, you have to have a clear-cut idea about your definition of the disease. So let me tell you the definition, operational definition of the definition, a definition by which the disease or condition can be identified and measured. So here two factors are we are dealing with. One is identification. So for that also you have to have a checklist. And second one is measure. You have to have a standard measurement tool to measure that particular health problem, to identify the affected population with a degree of accuracy. So that after, if you once finalize the case definition, you must adhere to throughout the study. You cannot change in between the definition of the disease. Third step is describing the disease. So first we have done two steps. One is we have defined the population, we have defined the disease of interest. Now third step is we are going to describe the disease. So this is the primary objective of the descriptive epidemiology, to describe the occurrence and the distribution of disease or health related events or characteristics within populations by three factors: time, place and person. So identifying the characteristics associated with presence or absence of disease in individual. Once you can, once when you have the information about time, place and person, then you can correlate with other factors. What are all the factors is present and absent among the disease and those who don't have the disease. And this is nothing but grouping of variables according to time, place and person. That is, the descriptive epidemiology is nothing but grouping of variables based on time, place and person. So here it is not a classification of causal factors. But the importance of this descriptive epidemiology is, this is the baseline for any kind of study. If you can take any kind of study, whether it is an observational study or an analytical study, that is the even the interventional study or experimental study design, you have to first of all describe your study population, then only you will be moving on to your main objective. So let me give you some examples how we can deal with this time, place and person. It can be, the time can be a year or a season, month, week. It can be a day or hour of onset, say like in outbreak investigation, and it can be a duration. These are all the possible list. And based on the place, it can be related to climatic zones. It can be a country or a regional level, or urban, rural, as I said earlier, and town, cities and institutions. Even we can say it can be a place category. And then coming to the person, you can describe the person based on their age and birth order and the family size and the gender, marital status, based on their height and weight. And from then you can calculate the BMI or the basic measures of blood pressure, blood cholesterol and personal habits. And also some of us might be interested in occupational related hazards or socioeconomic status or the education. These are all the possible list. It is an endless list. You can add based on the characteristics of the time, place and person. So now next we are going to elaborate little bit on time factor. So this is the overall flow chart. Don't get scared with this flow chart. This is the overall chart of the time trend, how it can be classified based on its nature and the duration. So first of all, time distribution can be mainly classified into three. First is short-term fluctuation, second is periodic fluctuation, and the long-term or secular trend. Anyhow, I'm going to deal with one by one, so don't worry. This short-term fluctuation further can be subdivided into three categories, such as common source epidemic or point exposure epidemic, and propagated epidemic, and the third one is slow epidemic. So this periodic fluctuation can be subdivided into two categories. One is seasonal trend and the cyclic trend. And then coming to common source epidemic, it can be a single or point exposure, or the continuous or multiple exposure. And this propagated epidemic can be further subdivided into three types. One is it can be transmitted from person to person, or it can be transmitted through a arthropod vector, or it can be due to a zoonotic disease, that is animal reservoir. So let us go one by one. First one is short-term fluctuation. This is, in another words, it can be called as epidemic. What is epidemic? So the occurrence of cases of an illness or any, say, like a dengue or malaria, whatever, you can replace in the appropriate places, or other health related events clearly in excess of normal expectancy in a community or region. Especially this group, you might be well aware about in your local community, in what are all the months the malaria will be, the cases of malaria will be high, or the dengue will be high, or any enteritis kind of diseases will be high. So if you could, it could be a evident the high number of cases in a particular time duration. Example, seasonal trend of dengue in India. So how we can classify this short-term fluctuation? Three types. One is common source epidemic. Here, don't get confused with all these terms. Let me explain. Let me simplify one by one. It can be a single exposure or point exposure epidemics, and or continuous or multiple exposure epidemics. So let me go to the next slide. It will be much clear. Okay. Now coming to the common source or single exposure epidemics. I can explain with a simple example of, if a group of people are attending in a wedding or a birthday party, they might have exposed everyone, they might have exposed to a common risk factor or common exposure. So that is the point source. If they are getting some food poisoning by eating a food which is served in that gathering, it is known as a point source epidemic. So here it is clear that the risk factor is a single exposure, and also the duration of the function or the event only, that is the exposure time. So exposure is brief and essentially simultaneous, and frequently but not always due to exposure to an infectious agent. Usually it will happen with an infectious agent, but it can be the contamination of environment by industrial or chemicals or pollutants as well. So a graph of the time distribution of epidemic cases is called the epidemic curve. Now here I am introducing another term which is very, very important in plotting the cases in epidemics, is the epidemic curve. So the example I have given here is the epidemic of food poisoning. Let me show you the epidemic curve. This is a time relationship with exposure to a suspected source. So this curve has usually one peak in common source single exposure epidemic. What does it mean? This peak denotes that at which time point the maximum number of cases get infected. So, and another point of interest here in this graph is median incubation period. That is the time required for 50% of the cases to occur following exposure. That is from the first point, the first person get infected, and the maximum number of, that is the maximum number of people get infected. That is the time duration. So this is known as median incubation period. So here this single peak curve is a classical example of a food poisoning outbreak. So here that it is shown in another way. It can be drawn as a histogram in the initial. Then if you could able to join the midpoint of the bars, you could be able to get the epidemic curve. Next one is common source continuous or repeated exposure. This is also a common source as like the first example given, but here it will be a continuous. That first one is the time bound one. Here it will be a continuous or repeated. So exposure from the same source may be prolonged or continuous, repeated or intermittent. It is not necessarily at the same time or at the same place. The best example for this is a contaminated well. If a village or a hamlet, the people, the population who are living in that village, if they are getting a drinking water from that contaminated well, they'll be exposed continuously to the same source, which is the risk factor which is spreading the disease. And here there is another variation of this model. What is it? An epidemic may be initiated from a common source, as like the contaminated well, and then it will be continued as a propagated epidemic. Again, another term is now getting introduced, which is propagated epidemic. I have already shown you in the flow chart of the time trend, which is nothing but how the infectious disease that is spread to one person, or through arthropod vector, or it is a zoonotic type. That is a classical example given for this model is when this cholera, anyhow it is a waterborne disease, it might be a common source initially, but after a person getting affected, that particular person can transmit the disease to n number of person. So it will become a propagated epidemic. So this is the epidemic curve drawn for this common source continuous or repeated exposure. Now you could see the difference between the point source and the repeated exposure. Here we could not see any single peak or any disappearance of suddenly. So it will be a continuous process. Then coming to the propagated epidemics, as already explained, it is most often of infectious origin, and it results from person to person transmission of an infectious agent. Example, epidemics of hepatitis A and polio. And the epidemic usually shows a gradual rise and tails off over a much longer period of time. I'm talking about the epidemic curve. And the transmission continues until the number of susceptible is depleted, or susceptible individuals are no longer exposed to infected persons or intermediary vectors. Until then, the curve will be continuous. And the speed of spread depends upon herd immunity and the opportunities for contact and the secondary attack rate mainly. And it is more likely to occur where large number of susceptible or aggregated, or where there is a regular supply of new susceptible individuals. If say like if a group of people given birth and the migrants are coming in, that is the new susceptible individuals. When they will get exposed to the already infectious person, they'll be contracting the disease. So this is the curve for propagated epidemics. So now you could able to understand the difference between among the three types. This slide shows and explains about the periodic fluctuation. So the second type of time trend is periodic fluctuation. So it can be a seasonal trend or a cyclic trend. You might be very much aware about the seasonal trend, especially the vector-borne diseases. So it is a well-known characteristics of many communicable diseases, this seasonal trend. Seasonal variations of disease occurrence may be related to environmental conditions such as temperature, humidity, rainfall, overcrowding, etc. Say like example, measles and varicella, it will be much affected during the early spring. And upper respiratory infection in the winter months, and bacterial gastrointestinal infections during the summer months. In contrast, what about the cyclic trend? These type of infection occur in cycles spread over short periods of time, which may be days, weeks, months, or years. Here one example is given, but it happened during the pre-vaccination era. Measles every 2 to 3 years, rubella every 6 to 9 years. And it was due to naturally occurring variations in herd immunity. Until the herd immunity is there, it will not affect. When the herd immunity decreases, as I already said, when the number of susceptible person individuals are increases in that community or population, again the cycle will restart. A buildup of susceptible is again required in the herd before there can be another attack. For example, influenza pandemics in 7 to 10 years interval. And a simple example, another one is automobile accidents in US weekends, especially on Saturdays. It will be applicable to all the countries. So here you could see the seasonal pattern of rubella, influenza, and rotavirus. 3 patterns here it's given. It is based on the timeline of months. Actually, up to March to up to November, it is given for all the diseases. And then coming to the third type of time trend, long-term or secular trends. Here, only one point you have to keep in mind, it might be have started as a single point exposure or a common source epidemic. But in a longer run, the changes in the occurrence of disease, that is progressive increase or decrease over a long period of time, generally several years or decades. The good example of for this long-term or secular trends is in the developed countries recently, the consistent upward trend of coronary heart disease and lung cancer, and the decline of infectious disease such as tuberculosis, typhoid fever, and diphtheria, etc. So now coming to the place distribution. Place distribution, it's nothing but the geographical distribution. So geographical studies profoundly influenced our understanding of disease, its nature, its detriments, and its relation to subsequent pathology, because it is a geographical factors are very crucial to identify the problem and to plan for the health provision and for the healthcare delivery. So as we all know, world is not a uniform unit. So it just differs with the culture, standard of living, and external environments vary greatly. So geographic patterns provide an important source of clues about the causes of the disease, which is the first step of epidemiological investigation. So how can we classify the place distribution as like time trend? It can be an international variation, national variation, rural-urban differences, or the local distributions. Here I have given few examples for that. You can go through. International variation, say like malaria in Africa, it is very prevalent, and chikungunya, Africa, Asia, and the Indian subcontinent. In the national variation, Kala-Azar is most prevalent in Uttar Pradesh, West Bengal, say like in 4 states, and Japanese encephalitis in Uttar Pradesh and West Bengal. And rural-urban differences, it is the best example is zoonotic diseases and soil transmitted helminthic diseases in rural area, and the accidents and cancer lung most prevalent in urban area. And another one is local distribution. It may be a inner and outer city variations. So this is the classic example is the cholera outbreak explained by John Snow. So this is the example of a spot map, which gives you the idea of what are all the geographic areas affected in which duration. Here we can have time, place, and person actually. One is the time is mentioned as 2 different timelines, that is 1968 to 1981, the first graph, and another one is 1982 to 2000. And how they have classified? Based on the age adjusted mortality rate. So age 0 to 2 to more than 2 to 4. So various kinds of groups based on the age. So you could observe all these 3 factors in the single map. So now coming to the person distribution. In descriptive studies, the disease is characterized by age, gender, occupation, marital status, habits, social class, etc. Foremost important is the age. Age, which is strongly related to disease than any other single host factor. Because we all know some particular problems, it will occur only in the pediatric group, that is the children, among children. Some diseases may occur in the middle age, some may be in the geriatric population, older age group. Example, measles in childhood, cancer in middle age, and atherosclerosis in old age. So age is a strong descriptive factor for the host factor for describing a disease. And next, coming to the sex, gender, a factor which is often studied in relation to disease, and even it can be used for to measure the occurrence of the problem. An example, sex specific mortality or the morbidity rate. For example, lung cancer and coronary heart disease are less common in women. On the other hand, diabetes mellitus, hypertension, hyperthyroidism, and obesity are very common among women. And the next factor, person distribution, is ethnicity. Differences in disease occurrence among subgroups of population. So in some of the ethnic group may be susceptible to get some particular infectious disease and non-infectious disease such as tuberculosis, essential hypertension, coronary heart disease, and cancer. So here it may be due to the genetic variation or maybe due to the environmental factor variation. And continuing the person distribution, next one is occupation. Here the example has given like sleep pattern, alcohol, smoking, drug addiction, and night shift. Here it is the mixed type of factors, risk factors, because they may alter in a particular some occupation, they may alter the habit pattern of employees. It may influence their habits or behaviors. So it can be occupation specific risk factors such as risk of silicosis among coal mine workers, risk of heart disease among sedentary occupations. And another important category is the social economic class. Health and disease are not necessarily distributed in different social classes. Example, coronary artery disease and hypertension and diabetes mellitus among upper socio-economic class, and obviously the nutritional problems, malnutrition in the lower social class. So this is the example given for this age. Based on the age, the Japanese encephalitis incidence is shown in this graph. So with this, I conclude this lecture. Thank you so much.